Good afternoon, everyone, and welcome. It's noon, so we'll go ahead and get started. I'd like to welcome you all to the Fairbanks Ethics Lecture Series, which we've been holding for the last little more than a decade. My name is Paul Helft, and I am the director of the Charles Warren Fairbanks Center for Medical Ethics, and pleased to welcome you here for our talk today entitled Population Health Management, Ethical Themes and Points to Consider. Just a few housekeeping items. Applications for our Ethics Fellowship are currently available. You will notice a flyer on the outside tables. If you or anybody you know is interested, please send them our way. Information can be gotten from our website. The application is on our website, but we're delighted to talk to anybody who's interested. This lecture is being recorded and broadcasted today. Those are joining us from IU Health Ball Memorial, IU Health West, Arnett, and Blackford. I'd like to welcome all of those groups. If you wouldn't mind looking at your cell phone and seeing if your pagers and cell phones are silenced, and if you need to take a call, just leave the auditorium outside. There are phones located across the hall in the coat closet. Dr. Ivy has no relevant conflicts of interest, so it's my pleasure to introduce Dr. Ivy. He happens to be my boss, so I found a few nice things to say. He has served as the Senior Vice President for Values, Ethics, Social Responsibility, and Pastoral Services here at IU Health since 2000. And it was his original idea to create the Fairbanks Center for Medical Ethics, so we owe him a debt of gratitude for that. His leadership roles include developing the 19 hospital systems, philosophy and practices related to mission, values integration, nurturing spirit in the workplace programs, sustaining both organizational ethics and clinical ethics programs, ensuring effective community involvement, developing palliative care programs, and focusing chaplaincy, pastoral education, and congregational health programs. And then he goes back to his real work, I guess, after all of that. So he teaches at the Christian Theological Seminary. He's been a senior affiliate faculty member at our center for many years. His current research focuses on education of medical professionals and community regarding care of persons with advanced illnesses. This work has been supported by grants from both the Walther Foundation and from the Methodist Health Foundation. So it's a great pleasure to welcome him here to give our lecture today. Thanks, Steve.
Thank you, Paul. Over the course of time, I think this is the third of these lectures I've had the privilege of doing. Might be the fourth. After a while, you just lose count of such things. And it's always a real joy and pleasure to do this. I do these kind of presentations for several reasons. It is contextual. This one is because this thing called population health management is one of the strategic priorities for IU Health over the next period of time. And few of us know what that means. And so your Values Committee of the Values and Ethics Committee of your Board of Directors said, we don't really know what that means either. Let's do a study of this. So the Values Committee of the Board spent a year with periodic presentations and asked that we particularly attend to the social ethics and clinical ethics implications involved in this. So that was the genesis of this. And I say that to you for those of you who are part of the IU Health family to say, your board gets it. They know they don't understand, and they care about the social responsibility and the ethics that matter in this organization. Now, the presentation that I did was 6 months ago with the board, and so this has evolved quite substantially since then. So I don't. So they would not have seen this. They have, and it should not be taken as approval of your board about what I'm about to say today. With that, I will be critical throughout the presentation, but please do not take that to mean that I think negatively about directions we're going. If we don't think critically, we can't be wise. And so I hope that I may have garnered a little bit of wisdom. The last thing I'll say by way of introduction. I found this presentation to be one of the hardest I've put together. Those of you who know me know that I tend to be a synthetic thinker. I like to get a lot of different ideas, put them together, figure out what's related to what, and come up with what seems like a good conclusion from that. There has been so little published about the ethics of population health, either the social ethics or the clinical ethics, that I simply could not do my usual synthetic stuff with this one. So what you find is my thinking here. You will do me a great favor where you can affirm what I have to say. Let me know. And where you think that I have gone astray, I really need to know that. It would be a great help. So the deal is, my email is there for those of you outside the system. For those of you inside the system, you know how to find me. Please drop me a note if there are some things in this presentation that particularly resonate with you or aspects of it that just don't make any sense to you. So I'd like to give you where are we headed. I will seek to support these points as we go along. The most relevant ethical issues, ethical themes involved in this study will have to do with justice and stewardship. If population health management means anything, it needs to address those elements of an ethical framework. We will find that the meaning of autonomy and informed consent must be reconsidered in a population health management form. It's not the same. It cannot be the individual patient and individual practitioner responding to each other. There's a much bigger frame of reference, and thus we have to ask, what does informed consent mean in that new frame? Population health management is driven by metrics. It measures a lot of stuff. And what we have to remember is that what we choose to measure is an ethical choice. And every measurement that we make, we should ask, what are the ethical implications of measuring that? Because measuring that usually means we're not measuring this. And thus, we have become blind to something because we have chosen to know something else. What are the ethics of that? And finally, yes, this is about resource allocation. No use bouncing around any way around that. We are allocating resources. Is this a wise and ethical way to allocate our resources? So some of you, you don't remember the history very well, so maybe this will help you remember history a little bit. A few of us, I actually remember as a child, the doctor coming to my house to see me. Well, a few nods out there. That's interesting. Some of you deserve to be called senior too, I guess, huh? Then the office call. Then this would be probably the 90s when we got a hold of HMOs, et cetera, the insurance company got in the way, supposedly, between the physician and the patient. And maybe this is where we are today. We have lawyers and bureaucrats and insurance companies and probably senators and et cetera who are between the physician and the patient. This is the status, and population health management lives in this context. It doesn't create this context, but it lives within that context. So what is population health management? This is an overview. This is a very high statement of what I understand that to mean. It is not to be confused with population health. Population health is a different category of understanding. They're related categories. Population health has to do with the health outcomes or the health status of groups of people, large groups. It has to do with things not simply their bodily physical condition, but it has to do with the wide range of social, educational, functional conditions that large populations live with. So population health, if we looked at a category of things belonging to population health, would have a lot of categories, and I'll show you these in a moment, that medicine does not address. And it becomes questionable then, how much should medical institutions claim responsibility for those? Now sit with that for a moment, because I just changed a little language on you. I changed from health institutions to medical institutions. And I'm not going to dive down that rabbit hole, even though it's one of my favorite to dive down. But I do think that if we don't be clear about the difference between the overlapping constructs of medicine and health, we will distort what we're trying to do. Population health is the big term. Population health management is a more narrow term that asks the question, how do physicians impact, how does the medical community impact clinical and financial opportunities to improve health outcomes? So it's a much more limited. And we had the recent illustration ongoing and in some places in our own state of a governmental entity choosing a means of delivering water to a population that poisoned it. That is population health. Delivering clean water. Medical intervention is dealing with the results of that poisoning. Population health asks, what is the medical community responsible for as the whole? You know, when something gets its own journal, that means it's real, right? You don't have journals talking about something that's not real. So population health management has its own journals now. So this has a broader understanding. I think it would be clear if health outcomes, patient engagement, reducing costs, than what we have traditionally thought of as the responsibility of acute care. So we're shifting gears with population health. Now take note before I go any further that what IU Health has said is we're going to pay attention and be outstanding, deliver excellent services in both acute care, quaternary, tertiary care, and in population health management. We're going to do both of those. They are different enterprises. They do different things. And we're saying we're going to get really good at both of them. That's a challenge. There's not many medical systems that are choosing both paths. Most are choosing one or the other. We're saying our duty to the people of Indiana is do both at an outstanding level. Yes, it's about the money. Both, this is what we're going to get paid to do, but more importantly, in the macro system of things, the medical care system drawing down 20% of the gross national product every year is simply not a sustainable enterprise. We have to figure out how to do our medical care better and at less cost. We believe population health management is one of those. And we believe that population health management at its core is a patient-centered care. Now, it can end up not being so patient-centered because all of us have been to physicians, and because of population health management, particularly our primary care physicians, must record all kinds of documentation to make sure that the standards they are being held to are documented. And it seems like that the physician may be more interested in the computer screen than me. I've had that experience. You have too, haven't you? So we can lose the patient-centered, but ultimately population health management, though it's about managing large groups, it's about the well-being of the patient in front of me. So how does that happen? Population health management, an improvement model, highlights three components of the medical system. First of all, the primary care physician. The primary care practitioner and those that the primary care practitioner focuses on are at the center of a population health model. Now, what we know is that the second element is the patient. Population health looks to the patient to be engaged and to be, what the phrase is, activated as a patient, and to be responsible for those portions of their life that they need to be responsible for. And the third element that you will see on this definition is it's a team approach. It does not involve just the isolated physician, but we find that in population health management, there's even more importance for, in the primary care setting, the variety of resources such as social workers, such as healthcare counselors, such as spiritually integrated therapies, all of those to really meet the whole needs of the whole person must be in the primary care setting. Now, we're early into this. We don't have too many of our offices, I think, which have fully implemented this, but we have a couple of pilots that have, and I'll talk about those a little bit as we go along. So keep in mind that triangle: the primary care practitioner, the patient responsibility, and care coordination. Now, there's one element of this that is left out of the definition, and I think from an ethical, social ethics critique, we need to call attention to now, and I'll say more about. And that is, who is left out of this definition? The patient's entire social system. So, illustrate that. Noreen, have they added a reimbursement code for kale and yoga yet? So the primary care practitioner is saying, I know I'm to treat this patient holistically. But if this guy is like most of us guys, he is not the one buying the kale. And he's probably not the one cooking the kale. As the doc talked to the wife, who is probably the one buying and cooking the kale. So the guy's going to go home and he's going to say, honey, go buy some kale. The doctor said for me to eat kale. And what is she going to say? What the hell is kale? And why would we want to eat that? And so a part of what we have to get through, if we're really going to practice a holistic population health management strategy, is that it has to involve the significant people in the community. We might even go farther and say, yoga? Where does this guy live? There may be yoga classes relatively close to him, since, well, in this photo at least, he looks to be a middle-aged white guy. He probably has access to yoga places if he wants. But if he was a different ethnic origin or not middle class, where is he going to go find yoga? So the entire structure around the patient in the community becomes important as well. For population health management to actually reach the objectives of having improved health throughout a population, we have to include the entire social network. And that is not something that medicine has been good at over the last 30 years. Can we actually make that change? Another graphic to try to help understand what are we talking about. We all probably in this room remember the good old days of fee for service. The doc saw the patient, they got paid for seeing the patient, and that no one measured whether the patient got any better or not. And we knew if the patient got better, but no one measured that. We're in the middle now of a transition, which we call value-based payment. Value-based payment, well, it's not just seeing the patient that matters. It's where the quality checkpoints hit, probably focused on process improvement. Did we do the steps we said we were going to do? And are those steps the evidence-based steps to improve health? But we today don't do a lot yet of asking, And by the way, is the patient healthier? What population health management sends us to is this care coordination side, where we actually ask the question of, did what we intended to happen with this patient actually happen? And that gets recorded. And guess what we get paid for? Whether it really happened or not. Kind of for those of us within the hospital setting, the nose under the tent for this is what? 30-day readmissions. That's the nose under the tent right now. And if we don't meet our targets for limiting 30-day readmissions, we do not get paid as much as if we did meet those targets. The assumption there is if we do our job well, and that includes follow-up after the hospital, most patients will not need to come back in 30 days. If we don't do our job well, including follow-up, they will come back and folk are saying, and we're not going to pay you for that. That next readmission is yours to take care of, and we're not going to reimburse you in the future in the same ways that we have. That is a part of population health management. Now, for those of us in areas that tend to serve a large number of impoverished patients, what do we then reply immediately with? Oh, their home situations, we can't keep them at home. Their home families, they're broken, they're homeless. And what is being the pushback on that? Then you'd better get involved with the homes. You'd better get involved in your communities. If you have a bunch of homeless people you serve, what are you doing to ensure that they have shelters to go to? Because as a healthcare system, we're not asking you those kind of questions. Now, those measures, by the way, are somewhat risk adjusted. Poverty is one of the risks that gets adjusted for. So we don't have absolute responsibility for that. But we do have some responsibility for those things. That's what about. So this complicated slide, this is one that Dr. Jonathan Gottlieb uses, our System Chief Medical Officer, when he tries to describe what population health management is about. It's a very, I think, nice slide. Just to walk through it quickly. Population health monitoring, that means we have to have robust clinical systems that we're able to get data out of. IT matters a lot in population health management. We do health assessments and then we stratify for risk. And here's where it gets interesting. On the care continuum, there are patients who have no or low risk. And what we know is that is about 58% of patients are right here. What do we do for these folk? We do preventative checkups, we provide some education, and we say, please keep being well. There's then the moderate risk, health risk management. These are the folk who tend to have maybe one or two very well managed chronic diseases. This is about 15% of folk. I happen to be in this category. Have a little high cholesterol that's well managed with lifestyle and a little medicine. And I have a growing arthritic hip that doesn't prevent me from walking 18 holes of golf. So really a little risk here, but no problem with it. We go over here, care coordination and advocacy. These are folk who have multiple chronic conditions that tend to be less well managed. Okay, we have about 16% of our population falls into this group, care coordination and advocacy. These are folk who we really, who we have to be very careful with to make sure they're getting full attention of primary care, that they're getting to specialists, that we're understanding, are they buying their medicines? Do they know how to take their medicines? If diet is an issue, if exercise is an issue, we become very engaged and try to, quote, activate this patient. Then we have disease case management. These are the folk who have several complex diseases that are frequently not well managed. Our goal here is to help them manage as well as possible out of the hospital, and when they do need hospitalization, to make sure they don't need to come back to see us for a long time. So those are the categories. Now, the ethics of that continuum, I want to unpack with you. What we know is that these two categories, about 30% of our patient population, will utilize about 70% of the resources each year. 30%, 70%. That's true pretty well across the board in all kind of insured groups. Now, an interesting social ethic question. We're asking these 70% to pay the same cost of insurance each year that these folk have. Is that ethical? Is that responsible? That's another talk. I would argue it is, but can you see how the question gets raised? These folk, especially this group, are hardly using any medical resources at all. But their insurance rates and premiums are going to be the same as these. IU Health, when you buy your insurance, we don't ask which of these categories do you go in. We just insure you. So that's an interesting challenge. We then have the person at the center of the paradigm, surrounded by community resources, general culture and environment, and the tailored interventions that we might provide for them. And then a variety of program outcomes that I won't discuss today. That's the general model of what a population health model of care looks like. So another definition, practice-based population health, is an approach to care that uses information on a group of patients within a primary care practice or group of practices to improve the care and clinical outcomes of patients within that practice. So we ask within our practice, how many of our folk have COPD? What are the best evidence for keeping COPD people as healthy as they can be and out of the hospital? How many of our COPD patients are receiving that intervention? We have X number of patients who are diabetic within our practice. What are the evidence-based practices for helping diabetic patients maintain their sugar levels and be healthy, live healthy lives? Are we providing those interventions? And are the patients actually showing the outcomes that we want them to have? That's the population health cycle. So what are some of the points that I would want to make out of this from an ethics perspective? First, the person at the center of the framework. Who is this person? Are we considering that this is not simply a biological organism, but is also a social being, is also a spiritual being? Talking with my wife, little anecdotes sometimes will illustrate, though they don't prove anything. Talking with my wife, she has a friend, a teacher friend, who is from a Mexican culture. They came here to teach. Her husband recently got a diagnosis of heart disease that requires a fairly massive change of lifestyle for this family. They have resources to do that, but as my illustration earlier, he received all the information about the lifestyle changes needed, including the kind of foods that needed to be cooked. And no one ever talked with her about how do you use those particular foods in a Mexican style of cooking, which is what her family knows. She tried to do the North American way of cooking, and they couldn't even eat it. Partially because of the taste, but partially because it wasn't the style they were used to. Who is going to work with her? Because it's a social experience. So in this case, we have a motivated, activated patient and wife who have not been resourced in their whole self. Will our primary care strategy involve that? Health promotion. Sometimes we think, well, let's just give them the best information and go on. We should never be under the illusion that health promotion is morally neutral. What we choose to say and what we choose not to say has moral consequences. And it is not morally neutral to simply say, well, we're going to say the truth. How we say the truth matters. Who we say the truth to matters. And the way we frame that truth and whether it's actually true for that population or not. We tend to come with cultural worldviews to our health promotion. We assume the majority culture. We assume an individualistic approach. And there are many cultures that simply does not fit in. And whether we're choosing to be paternalistic or maternalistic with this, it is still not recognizing racial, cultural, and social differences. If we're using the same health promotion to address the upper 5% income population and the lower 5% income population, we are missing one of those, I promise you. That is a morally challenging position to be in. For those with health risk management, who gets to determine what a quality of life looks like? I assure you that what I thought a high quality of life looked like 30 years ago looks pretty different today. I suspect that's true for most of us. And I know from my 90-year-old mother that what a high quality of life looks like for her is really different than what I consider a high quality of life. How do we fit those kind of age differences into our risk management when we start talking about a quality of life approach? Remember, health risk management are those folk who have one, maybe two illnesses that can be managed and are being managed relatively easily. What are we going to do for quality of life there? Then for those folk who require care coordination, how do we manage to do that kind of coordination without coercing someone along the way? This is where I want to jump into the autonomy informed consent. We may be dealing with the patient, but we're messing with the diet for an entire family. Should the entire family be present and give informed consent? To get out and walk, which is for this group frequently the best exercise that they can get, is to get a regular walk in. And they live in a neighborhood where the broken sidewalks make it really dangerous to shuffle along on the sidewalk. Do we need the informed consent of the son who lives 15 minutes away because he's going to have to come pick up dad and take him to a safe place to walk, or the man's not going to walk because it would be harmful for him to walk on those broken sidewalks? Who needs to be involved if we're really going to do care coordination? How broadly can we drive that forward? In this realm, we also have a huge need for medical health counseling, for people who are experts in helping folk change behavior. Very few physicians have studied how to help patients change behavior. It's not a skill set we expect of our physicians. But this is about behavior change. Do we have the resources available? And how can we hold people responsible for changing their behavior if we do not provide them the resources they need to do something different? Now, if you're sitting there thinking about your own situation at all, just take account of your own efforts to change your diet or your exercise pattern or your getting up time or your going to bed time, any of the kind of ways, and how difficult it is for us to do that. But we're saying to a physician without behavioral change expertise and to a patient who has a way of living they're motivated to change, but motivation does not change us. You better do different. And by the way, Doc, if they don't do different, we're going to deduct a certain amount from your paycheck each month. Coercion becomes very, very present, not only to the patient as a possibility, but to the primary care provider as a possibility. A very real danger. And then those sickest patients, those who come in the disease management, have many of those same kind of challenges. So with this kind of model to help us understand what population health management is about, this is a similar model making the same points. What does it do? We define the population we care for. We identify gaps. We stratify risk. We engage our patients. We manage their care. And we measure the outcomes. That's what population health management does. So the question is, what are we doing with population health management? What are our practices at IU Health? Today, we have about 180,000 lives that we cover through a population health management program. These are people who are enrolled either in IU health plans or in MedWise insurance plans. All of you in this room who are IU health employees and get your insurance through IU health, you're right here. Did you know you were covered life? You are. Did you know you're part of a population health management program? You are. So, which is maybe interesting, have we been transparent about that? Which, by the way, is another ethical point, isn't it? How transparent have we been about we have stratified you in your physician offices and have identified where on that continuum you are. Do you know that? This is from CMC, and you probably can't read this. I'm going to blow this up for you in a moment so you can see it. These are the community health assessment population health improvement metrics. So these are the categories that the CDC says there are good evidence-based metrics for measuring these things in. I'll go through each of these quickly, but the categories are health outcomes, mortality, morbidity, health determinants, health care access and quality, and health behaviors, and correlate measures, demographic, social environment, and physical environment. Those are the categories the CDC says we have good enough evidence-based metrics that we can actually measure those things. Now, before I go into that, another ethical point. These measurements, for the most part, depend upon an understanding of outcomes research that is a cause-effect standard. Most of our research depends on a materialistic scientific model that says there's a cause and there's effect, and if we can identify that, then we have truth, right? There are other ways of understanding truth. There are other ways than the cause-effect model that the universe may be stuck together. That's why the correlates are so important, but don't find their way into our measures. So just to give you an example, that we assume that all the variables are controlled for, most salient. There's IU School of Medicine research reported this week that it's discovered that for women who are suicidally depressed, there are biomarkers available to understand that they're suicidally depressed. They're not available for men. The biomarkers are not there in men, but they are in women. Who knew? A possible real progress for counseling and intervention with depressed women and being able to identify who among that group might be most suicidal and to do appropriate interventions. Notice how have we control for all the variables there? Are those present with women who have a sense of purpose and meaning in life? Well, that's kind of a difficult independent variable to throw in there, isn't it? It can be done, but it's really hard. Are there more circular reasoning available? So this gold standard that we have about these kind of pieces, the human being at the essence of healing and well-being, is that a total human being, body, mind, and spirit? Are we just looking at the body? How inclusive are we being in what we mean by being human? And finally, whenever we decide we're going to measure something, we see that thing clearly. And it means we're not looking at this thing. So if we don't ask the question of what are we not paying attention to, what will our lens not show us, will we then be able to have a truly ethical sense of what that is? So what is IU Health measuring? Again, we'll blow this up for you in a moment. But out of all of these things, these arrows point to the areas, 1, 2, 3, 4, 5, 6 areas that IU Health in our population health metrics has a measurement for that we're accountable for this year. There's 12 of those. So sure, it's an innovative approach, but it's never been done before. We can't do that is frequently our response. But I think some very interesting things are happening. So one of those columns was mortality. And in mortality, those areas right there are the various areas that can be measured according to the CDC. What IU Health is measuring under that are these 4 composite measures. Now, they have to do with a number of identified problems and that they are able to extend across various populations. Just to quickly describe those for you. This composite measure here has to do with diabetes, LDL, blood pressure, tobacco use, and taking a daily aspirin. And so this asks how well do we do with those preventative measures. Colon screening. If you're over 50, have you had a screening in the last 9 years? That's why when you go in to see those of you who turn 50 and all of a sudden your primary care doc gets real interested in a colon screening. Well, why? It's on their list of things they have to get done. Or they will get dinged for that. Is hypertension controlled? And then a pediatric adolescent depression screening. So those are the areas that under mortality your doctor is responsible for. It doesn't cover all, but it's a very broad measure of what matters for mortality. Under morbidity, these are the elements CDC says can be attended to. In this area, we're measuring more impact on obesity, hospital utilization, and overall health status. But we're not measuring low birth weight. And by the way, the reason for that we need to put a star by that is being deeply attended to statewide in very different areas because Indiana has such a bad record with low birth weight and with infant mortality. So that is being attended to. That's why we didn't put it in our metrics. Motor vehicle injury, sexually transmitted diseases, TB, all of those. And so we're measuring ambulatory care sensitive conditions, a variety of about 30 conditions that may lead to inpatient admission or an ER visit. To an ER visit here. 30-day all-cause readmissions. So hospital utilization, whether we're taking care of people in their home setting well enough that they don't have to come to the hospital or to the emergency department. It's a pretty good measure, right? Now, remember that slide? It is both patient-centered and, if done well, saves us a lot of money. And it saves you a lot of money on your insurance premium. We're in this together, remember. This question, to rate your overall health, has actually proven to be a very high correlation to almost all other health issues. A person who doesn't rate their health highly has something wrong with them. And so it becomes very predictive of overall health. Health determinant measures, for the most part, we don't measure. Now, up here, the one, we do have asthma in a couple of our ambulatory care sensitive conditions, so we pick this up a little bit. Health behaviors we pick up with tobacco use as the primary way, and then immunizations. And so to show that, we have two measures that we use with those. Again, this takes a very deep data bank and ability to be able to know what our physicians are actually doing. Then health correlate measures have to do with demographic social environment and with our physical environment. We do not have any measures here, though these are the kind of things that our community benefit plan can be addressing and is addressing in some cases. So if you go back a few years, it's not there today. For example, we had a number of years where we worked closely with Habitat. Why? Because there's a correlation between one's housing quality and one's health status. We have been closely involved with domestic violence groups and make significant contributions to those. And then some others. We work closely with educational institutions. So this is the place that community benefit initiatives begin to accrue, in contrast to what happens in the primary care physician office. Then we have a 12th measure, and that is this wonderful phrase, medical loss ratio. This is an insurance term. What this measures is our experience of taking care of patients in the outpatient setting able to do that at less than our insurance charges. Okay, it's simply to say because if we are spending too much money taking care of people and are not charging our insured population enough for that care, what do we have to do? Raise premiums or get a lot better at taking care of those populations at lower cost. You can see here 100 would be a break-even position. And some of our entities are not breaking even right now on this. And others are doing quite well with it. So that is with that. So we then have 5 programs this year. I'm not going to go through these, but just so you know, in addition to the primary care office visits, there's a number of programs that we have put in place that are beginning to try to address these outcomes. Trying to answer the question, what is IU Health doing? So what are the points to consider? First, notice that we've shifted the discussion from to collective responsibilities and common goods. Acute care medicine focuses more on private exchange and on the individual good. So we have a different paradigm at work. We are in population health management as a whole. We are all sharing in that. And whether you take your medicine for your high blood pressure matters to me. Because if you don't take it and you have high cost, it matters. We are in this together. How can we explore ways to actually capitalize on the social good that goes with population health medicine? Social and environmental determinants are not as important to this product as individual accountability, but they're not captured in patient metrics. So the social and environmental things are not yet embedded sufficiently to actually be allowed the impact that they have. Allocation of resources focuses on cost-benefit analysis. Some of these conditions, in fact most of them, are targeted because they are more expensive to provide acute care for. Why are we particularly interested in keeping that group of patients out of the hospital? It's because if they get there, it costs us a lot. Let's keep them out here. Now, it's better for their health. Don't hear me but also recognize that these may be chosen not simply for medical reasons, but for financial considerations as well. So other options that might focus more on improved quality of life are asking our patient population, well, what would you really like to achieve with your care over the next year? And let's measure that. That's not what we do. We measure on the basis of A, we know these are risk factors for good health, and B, we know it costs us a lot if we don't do it well. That's why we choose. I've been doing some research on the effects of plant-based diet, doctor, and it goes back to Hippocrates. So, well, he knew that most diseases can be avoided by just eating the right food. Oh, that's not what I was taught in med school. Well, why not? Well, Hippocrates didn't have to maintain a medical industry or answer to stockholders. So, treat the symptoms, not the cause, eh? Well, yeah, like any other industry, cash now trumps ethics. Overstates it a bit, but maybe not too far. What matters in this, we have to be very careful with. So what are some of the medical dangers that have to be watched for? First, we know there's a danger of deselecting those who will lower the success of a practice. I've had some direct consultation with our primary care docs around this, with some of the practices being very reluctant to accept newly insured HIP 2.0 patients. Why? They may have gone a generation or more, maybe forever, and never had health insurance. They don't know how to behave in relationship to a doctor. It will lower that office's scores. It will lower that office's income. They would like to avoid those patients. Now, that is not an accepted answer within our circles, but hear the struggle. At individual levels, if you're a physician and you have a patient who is simply refusing to follow what you think they need for their health, what are you tempted to do? Fire the patient. Get them out of my practice. AMA Code of Ethics actually tells doctors the steps to take to fire their patients in an ethical way. This is a danger. I am not aware of this happening among our groups. Let me be very clear with that. But do you hear the ethical danger? And it's reflected in the literature. There's a danger of incentivizing measurable behaviors rather than healing and healthy behaviors. Mindfulness-based meditation has been demonstrated to be as effective as most blood pressure medicines for most people. Not all, but for most. We don't have mindfulness-based meditation anywhere in this place to measure. But if you take your blood pressure medicine, we will give credit for that. We have to be very thoughtful about what we incentivize. Then there's the danger of gaming the system rather than providing comprehensive care of the patient. Gaming the system, well, you wouldn't get a presentation from me if it didn't have at least one Dilbert slide in it. I combined a DNA test kit with a big data to predict a person's future health issues. That depressing knowledge caused every member of the test group to make risky lifestyle choices. Now half of them are dead. At the risk of bragging, that's exactly what my model predicted. Well, danger of gaming the system. So let me summarize points to consider. Justice and stewardship are the guiding ethical principles. Justice is implied if healthcare correlates are included in our measurement. Quality of housing, food access, education, access to medical and social resources matter. How are we engaged as a system in the full range of health? Stewardship is implied by ensuring that resources are focused on preventing unnecessary pain and suffering, that resources are directed to efficient ways that actually achieve the end of improving the health of our communities is a wonderful aim and is to be affirmed. Where those resources are directed to simply those things we measure, we need to be very cautious. Number 2, shifting our understanding of autonomy and informed consent is implied. One's relational community matters. To tell a working male to improve his eating habits when he has almost no input into food selection or cooking methods is to ignore his lived reality. To tell a poor family who lives in a food desert to eat more fresh fruits and vegetables is to ignore lived reality. When behaviors are physically dangerous but relationally nurturing, will we be culturally sensitive and engage all those people who are involved in that situation? 3, what and how to measure is fraught ethically. Do we measure what is measurable simply because we can do it? Or is it really that important? Do we ignore dimensions of human being and human becoming that do not fit so neatly into a cause-effect box? Do we measure what creates only physical health? Or is social, psychic, spiritual health, one's happiness, actually a part of what we need to be measuring if we want to take health seriously? 4, resource allocation decisions need to be transparent to all affected. Most people who purchase medical insurance products do not receive benefit from those products equal to the cost in any given year, and indeed, most over a lifetime do not receive back what they put into insurance products. It's a community endeavor. Can we sustain a communitarian ethic where we all purchase insurance so that the sickest can receive complex care at great expense while the well receive support and education at minimal expense? I hope so. But communitarian ethics have not been so effective in our libertarian environment. Tried to offer a moral compass here. Whether I have well provided that or not, you can be the judge of with that. Have about 2 minutes if you have a question, a response. Amy has a mic, or I will respond and restate the question. Anyone like to comment? Right here.
Thank you, Steve. Really very interesting and a provocative discussion that you've fostered, and have a lot of questions that I'll be thinking about. One of which is based on your first point about justice and stewardship being guiding ethical principles. You know, every bioethicist will say, well, sometimes these things come in tension, and how do you prioritize one versus the other? Stewardship falls very nicely into our cost-benefit analysis type measurements. How can issues related to justice within our health system gain a foothold, perhaps gain priority when faced with such clear measurements that may be attached to the latter?
Yeah. Next question. I do think that having conversations about justice is something that we have to get to a level of civil discourse. Justice is a communitarian concern. And until we can have civil discourse at community levels, that's going to be awfully difficult to achieve. In the meantime, areas of interest. Are we actually engaging different patient populations to ask them, what do you value? Does this matter to you? And then adjusting what we do based upon that. We believe these to be the most important things to your health. Do you agree with that? These would be things we could measure, Would that be more important? So if we have within our circle of 180,000 covered lives, and by the way, we hope to push that to about 500,000 over the next 5 years. Within that circle, can we have these? Can we hear from our practitioners if we're asking them to measure what they think are really most important with that? So that would be the beginning. You have to begin in conversation, and community conversation is hard. One more question here.
I just wondered on your slide of the journal, it had the previous title of the journal underneath in small script, and I wondered if you regard that as just a semantic change in terms of the content, or a truly meaningful change in what's being reported.
You're speaking of the Population Health Management Journal?
Correct.
Yeah. No, I think they have actually changed focus of that journal, and they have shifted what they are paying attention to. Well, we have used our time. Thank you for your attention. I do really value hearing from you over what was good and helpful here and what you might want to challenge. Be well.